Hello, my name is Roger Blumenthal, and I'm editor-in-chief of the dyslipidemia clinical community, which is now available on CardioSource. Today it gives me great pleasure to talk with a good friend and colleague, Dr. Paul Ridker, Eugene Brunwald Professor of Medicine at Brigham and Women's Hospital. Today we'll discuss the new paradigm of cardiovascular risk assessment and how to manage dyslipidemia with lifestyle and pharmacologic changes. Welcome, Paul.
Roger, it's always a pleasure to talk with you and to be on the ACC web with you.
Well, Paul, you're clearly one of the world's authorities on risk assessment, and you just published a great paper in JAMA along with Peter Wilson talking about the importance of randomized clinical trials to see who would benefit from statin therapy, and I was wondering if you could summarize that for us.
Sure. So Peter Wilson, who, as you know, is the architect of the original Framingham risk score, and myself, as the architect of an alternative risk score, the Reynolds risk score, we were actually making the argument that perhaps it's time to move past using these risk scores at all and simply apply what we know from clinical trials to be true. We know from large-scale trials that pretty much everybody with a prior heart attack, so secondary prevention, should be treated with a statin. And we know in primary prevention that patients with a high LDL, that's Westcops and Mega, a low HDL, that would be AFCAPS, a high CRP, that would be Jupiter, that they benefit. And then we also learned that there are trials with very high Framingham risk scores where there's been no benefit whatsoever to our patients. Now that may surprise a lot of listeners, but we've got to remember that Framingham scores or even Reynolds risk scores are just predicting global risk. Well, we did trials in heart failure, we did trials in renal failure, where the Framingham scores are 35, 40%. Big LDL reductions with a statin, but no clinical benefit. So we're making the argument in the JAMA that maybe the time has come to stop using global risk scores altogether and actually believe what the trials tell us. And it's a very easy message for the clinical care community, particularly our primary care colleagues. Just treat these individuals and move on.
Well, Paul, that's a great summary. One of the things I wanted to ask you about, I know you had reviewed a prior draft of the guidelines, is the fact that they took this new risk score that's looking at heart attack and stroke and then applied it looks like, to MESA, multi-ethnic study of atherosclerosis, and the REGARDS trial. And one of the things that struck me was that the C statistic for MESA was around 0.7, for REGARDS it was 0.6. Perhaps you could clarify with the importance of that information and how that may indicate that maybe the risk score that they picked is suboptimal.
Sure, Roger. Well, let's start with the optimistic part. It's nice to see that after nearly 40 years, the new score includes stroke, not just myocardial infarction and cardiovascular death. We put stroke into our Reynolds risk score many, many years ago, and obviously for the clinical community, stroke really matters, and so I'm glad to see that there, particularly because we know that statins lower the risk of stroke. So that's a good step in the right direction. We also believe that revascularizations are a major endpoint for primary prevention, and why those are not included would be an issue of discussion. But that's generated in one place, work in a second place. So the C statistic, which is a measure of discrimination, the answer in REGARDS and MESA was, well, not that great. But there's another concept, Roger, which goes beyond just discrimination, which is what's called calibration. Does it actually predict the right level of risk, not just the ordering of risk? And that's where the new score, we are concerned that it may be overestimating risk a great deal. As you're aware, the new cut point of 7.5% to treat, I'm not quite sure where that number comes from. And it may well put a lot of patients on therapy where we don't have clinical trial evidence that the drugs work. And it may well deny therapy to a lot of patients who we do have clinical trial evidence where the drugs work, which is why Peter Wilson and I were saying maybe the time has come to not use these risk scores anymore, but actually trust the trials. There's another subtle issue, Roger, that I think the epidemiology community and the prevention community have to come together on. When we estimate a global risk, the really biggest predictors of risk are pretty much how old you are, which is something we can't change, but also the other predictors are, do you smoke or not, and what's your blood pressure? Those variables add a lot more than lipid levels. Well, I would argue to my smoking patients, you should stop smoking. And I think for our hypertensive patients, we need them under therapy. Well, so you're going to recalculate the risk at that point, or are we using these risk scores for the wrong purpose? So I'm concerned that using a risk score to prescribe statins may not be such a great idea. I'd rather get the blood pressure down, get the cigarettes away, and then, as I say, use the trials that we know actually work.
So, Paul, that was very insightful. Another point that I wanted to ask your opinion on is in this new document, they recommend that in individuals ages 40 to 75, that if you have an LDL of 70 to 189 and you're above that threshold of 7.5%, that the recommendation would be to treat. And your trial, Jupiter, probably has the greatest amount of data in people with what we would say, normal LDLs. But do we really have that much data that people with LDLs in that 70 to 90 range truly benefit from statin therapy?
Well, Raj, you make a very subtle but important point. I am concerned that our colleagues who put these guidelines together may have misinterpreted our own Jupiter trial. Yes, it is true that we had many thousands of patients whose native LDL was below 100, and it is true that when we gave them a statin, they had a substantial risk reduction. But you got to remember, every patient in the Jupiter trial had a pro-inflammatory response. Every single one of those patients had an elevated CRP, and that's what put them at high risk. They certainly were not at high risk because their LDL was 75, 80, or 90. They were at high risk because they had inflammation. Statin drugs are both anti-inflammatory and lipid-lowering. So how you can take that trial and make an assumption that all patients with an LDL of 75 or 80 need to be on a statin, I honestly don't know. I don't think the data are there. And again, it's the danger of not using the trials to dictate care, but that's where we seem to be.
Well, Paul, and then finally, I wanted to ask your opinion about blood pressure. In lipids, we have quite a number of studies, and your Jupiter trial is clearly the largest. But in blood pressure, it seems to me we can't take that same paradigm of just relying on randomized controlled trials. There's very little data that treatment of systolic blood pressures less than 160 really decrease events, and that's what a Cochrane analysis had said. So if we extrapolate in blood pressure, is there, in your mind, a reason to maybe extrapolate to an LDL target or a non-HDL target? And what will you do in your clinical care of patients who have the higher triglycerides and lower HDL? How will you manage them? Will it just be with a statin, or do you think there's still a role for an add-on agent, even though it wasn't part of clinical trials?
So again, Roger, the reason that the piece that Peter Wilson and I wrote in the JAMA was specifically about using a trial-based approach for statins is because that's the one area in all of internal medicine we have adequate data to actually base care on what the trials tell us. And I would argue if we can't get it right for statins, it's going to be very difficult to do it in other areas. You raise the issue of blood pressure. Now that's an area where we probably don't want to use just the trials because the trials that have been done don't actually mimic our current care. So we need in that setting to use more expert opinion and a more sense of what do we think actually works. You expanded your question to talk about LDL goals. My understanding is that the new guidelines are silent on targets and goals. The rationale for that is because the trials were not designed with goal comparisons in order. That being said, the PCSK9 trials that are now up and running are in fact going to be talking about taking from one goal to another goal very low, and so we can have some data perhaps 3 to 5 years from now about that. But I think what you're getting at, Roger, is the art of being a good physician. I know in your prevention center at Hopkins, you treat a lot of complicated patients who don't fit within the narrow confines of guidelines. What Peter Wilson and I wrote is that for those kinds of patients, maybe it's 10% of our population, 15%, referral to someone like yourself makes sense. And that gives you the discretion to say, in this setting, I want to lower those triglycerides. In this particular setting, perhaps the Lp(a) is high. I want to think about their HDL. What we were trying to argue, though, is that for about 80% of the patients and 80% of the time, a simple guideline would work. And then the referral on to a vascular specialist, a lipidologist, endocrinologist, would really be necessary for decisions about what do I do with second-line agents, what do I do with drugs where I don't have the trial evidence. Because clearly as physicians we understand This is not cookie cutter medicine, but you do have to have a pretty sophisticated knowledge base to make that next step.
Well, Paul, thank you so much for your fabulous insights, and I want to thank the audience for their attention today, and I hope you will visit the community frequently for ongoing information about dyslipidemia. We'll certainly be coming back to Dr. Ridker for other interviews. This is Roger Blumenthal for the CardioSource Clinical Community on Dyslipidemia. Thank you again.